this is a team effort that everybody has to be trained for. It is unlike anything else in medicine. I'm very serious.
Dr. Nii Carko, my buddy, how are you doing, my friend?
I'm doing great. Dr. Ryan Gray, what's good? How you doing?
I am great. I'm excited to chat with you. Number one, because you got the great, sexy radio voice. You got the microphone, and you're an osteopathic physician, which students have been dying for. You're the second one, 2 weeks in a row. And you're a trauma surgeon, which students will love because they like the blood and guts for some reason. The students love the blood and guts. So I'm excited to chat with you and find out more about your specialty and go over a great case with the students.
Awesome.
With that said, one of the best questions that has come out of these eShadowing sessions that I love to lead with is just, what is bread and butter trauma surgery? Which sounds like a complete oxymoron for like, what do you mean bread and butter? It's trauma surgery.
Yeah.
But there's got to be something trauma surgery, bread and butter.
So yes, it is kind of oxymoronic, bread and butter trauma surgery. Like probably the majority of people who go into trauma surgery love trauma surgery because it's not mundane, right? It's not the same thing. And whatever happens, you're just like, yeah, I don't know what's going to happen, but I'm trained well enough to figure it out, right? And that's the part that's super dope about trauma surgery. I think in terms of bread and butter, the things that we see on a daily basis, we're talking about the traumatic brain injuries, particularly in the elderly population. Right. So we're seeing the people who are in their 60s, 70s, 80s, 90s, who are also on blood thinners and they fall and they injure their brain. But, when you fall, you don't just fall and hit your head, you hit other body parts. So, we're talking about people who hit their head and then also break their hip. So we see that a lot. Depending on where you live in the United States, if you live in a rural or suburban area, you may see a lot more farm accidents. You may see a lot more suicide type injuries. You may see a lot of farming type injuries. If you live in the inner city, you're going to see more car accidents, like particularly on the interstates. You may see some assaults. You may see some gunshot wounds. It all kind of depends on where you live. But for the most part, those three scenarios are what you're normally going to see. But like I said, no day, no patient is ever the same, which is why I love it and why I keep coming back.
Yeah, to do that.
So, looking back now, and I know that a lot of people who are going to be watching are going to be like, yeah, easy for you to say, like, you already got through the process. But I have to say, outside of getting in, once I was in, the barriers that were there were pretty much all from me. Right. Mentally, like I would think that there was either imposter syndrome or I would have to be there at 4 o'clock in the morning because I don't want them to say anything bad about, an osteopathic medical student or osteopathic resident. But nobody said that to me. Right. That's all here. But yeah, so I worked harder than anyone else. I hustled harder than anyone else. But nobody ever on a daily basis said, you're an osteopathic physician. You got to do this. That never happens. Right. Yeah. It doesn't work like that. So for me, getting into an allopathic residency wasn't my initial plan. I initially was trying to get into an osteopathic residency, but this doesn't happen anymore. But basically, roughly about 2 weeks, 3 weeks before the osteopathic match was to occur, I got a call from a couple of osteopathic surgery programs that said, hey, look, we found people outside of the match. We're going to go with them and deuces, you good. And I'm like, yeah, but what am I going to do? And luckily, I was also trying to get into whatever program I can get into. So I was in the allopathic match also. So I just kept going. But then I decided to do and take a chance and do a sub internship. Some people say it's a sub I, but I did a sub internship at Morehouse School of Medicine at their critical care program at Grady Memorial Hospital. And the reason I did that is because Morehouse did not have a surgical critical care or some type of surgery residency for, outside medical students to come in. Mm-hmm. So someone told me, they're like, listen, if you come and you do this sub-I with the critical care team, you're always going to be walking right next to the surgery program, always, which is true. So I did it. I packed my bags. I drove down to Atlanta. I got into the program. I lived out of my bag and got there 4 a.m, bounced at like 6, 7, 8 o'clock at night. And I made it very clear that I really love critical care medicine, but I really love surgery, critical care. And right before I left and I was supposed to go on my next rotation, this is January now, right? Like by then, like a lot of the programs have already decided. But I matched at Morehouse. It was my second choice, but I matched there. And it was the best 5 years and the hardest 5 years I've ever had, but it was amazing. I loved it.
Yeah. So what it came down to was not what medical school you went to, not that you went to an osteopathic medical school. It was you as a person showing up every day with your work ethic, your attitude, and everything else.
Absolutely. Yep. I mean, that's the best way to say it.
Yeah. Love it. Love it. Love it. All right. I want to jump into a case, but so I'll let you do that. And then the next question that students want to hear is always, how long is the training path to become a trauma surgeon as you're pulling up slides?
All right. So how long it takes? So it takes 4 years of medical school. And then you got to do 5 years of a general surgery residency program. During those 5 years, you're doing a whole bunch of training and everything basically from here, from the brain all the way, you can't see my pelvis, but to the pelvis, right? But mainly focusing on everything from like below the neck to the pelvis. So we're talking about from esophagus down to, I'm going to be honest with it, to the anus, right? And then as you start to do rotations, you start to do more things and things related to what a normal bread and butter general surgeon would do, gallbladders, appendix, all those different things. So after you do your 5 years in that training, right, after you get all of the caseloads that you need to do, then you can go and practice as a general surgeon and do what you want to do, right? You want to go do laparoscopic surgery, or you want to do patients who are really heavy, the bariatric surgeons, you can do that. I decided that I wanted to do and become a trauma surgeon. So I went down to University of Miami and I did a trauma critical care fellowship. So there I'm all the time just taking care of traumatically injured patients or patients who need emergency surgery, like right now. And then I'm taking care of them in the intensive care unit. So a total of, after medical school, 6 years of trauma training, of general surgery and trauma training. And then from there, they let me fly, and I'm doing this, 7, 8 years later. So
nice. When were you at Miami?
I was at Miami from 2011 to 2012.
2011 to 12. Do you know a trauma surgeon there named Valerie?
No.
I think we played this name game before. She was someone who I went to high school and college with. She's also an osteopathic trauma surgeon. She's an attending at Miami now. But that's awesome. So the other cool thing is that our osteopathic guest last week at GI Doc did his fellowship at Miami. So apparently Miami is the hot place.
Something that really wasn't on my mind that much when I was applying. I was just like, let me get in and and do the best training that I can get. But yeah, it's you kind of look back on things, and when people ask these questions, that's why I prefaced it by saying, yeah, you went through the process, so it's easy for you to say, but it really is like, just spend as much time as you can to be the best student that you can be, and just know that whether you go to an MD school or allopathic school, you got amazing training. It's just really about you. You handle your business. So I got the presentation up. I'm sorry, I've been messing around with it, but I got it. I'm ready to go whenever you guys are. So everyone, let's do this. I'm all the way at the end. I'm sorry. Thank you very much, everyone. I love you all.
Thank you and good night.
Thank you and good night. So everyone, thank you so much for letting me talk to you all. My name is Dr. Nii Carko. I went to osteopathic medical school, Kansas City University of Medicine and Biosciences. While there, I did a dual degree program and got my MBA in healthcare leadership. And I'm proud to be a fellow of the American College of Surgeons. And you can also see there that I host a podcast called Docs Outside the Box. So look, let's jump into this case file. All right. I know you guys want to know what we do on a daily basis. So look,
my friend Valerie went to Kansas City too. So you guys got to know each other.
Really? What year did she graduate?
I'm looking it up. You do your thing and
okay,
I'll figure it out.
So listen, this group of girls right here, they just got this car, sister in the front. She just got her car. She's excited. She's got her friends. Look at them looking back. They're excited, having fun. None of them got their seatbelts on, though. Pay attention to that, right? So they're going out on a drive, right? They're happy as can be. And then all of a sudden they see a deer. Oh, snap. What do you do? So this is probably what most teenagers or people in their early 20s, what happens when you see a deer and you're having fun and so forth. It just looks like double vision. Everything happens so quickly and so forth. And you know what's going to happen next. Boom. Car flipped over multiple times. The other two people in the car, they're doing okay, but the driver is not doing too well. So EMS gets to the scene. The other two are able to get out of the car and walk. Actually, they get evaluated, and the EMS decides to let them go on their way. But the person who's driving the car is not doing too well, right? As a matter of fact, they want to bring her to the hospital. So they get her all ready. They get IVs in her, and they decided they want to fly her out, actually. So over the radio, they call in that, hey, we have a 23-year-old female who's been involved in a motor vehicle collision, right? She is a female driver. She has loss of consciousness, which means she's passed out, right? And then she's complaining of head pain. She's complaining of her abdomen is hurting her. And then she's also complaining of severe right thigh pain. Her vitals are stable. She's got no allergies. She's got occasional alcohol use, no medications. That's what they tell us over the radio. The trauma team gets ready, right? And we're ready to go. She comes and we are ready to see her. So that's the entire trauma team right there that's ready to go. And very briefly, the fact that they're able to let us know over the radio how this woman is doing is a groundbreaker, right? It allows the entire team to be ready to see this patient, to have all the equipment ready to go. There's no surprises. We have everything that we need to take care of this patient. And as soon as all we are waiting for is for her to get to the room. So when we look at trauma patients, we don't do a very long examination. We actually cut up our examinations into something that's called the primary survey and something that's called the secondary survey. The primary survey are things that I say are going to kill you in like 30 seconds. Okay. And then the secondary survey, I'll get into that later, are things that you can worry about afterwards. So the primary survey, always remember that are things that are going to kill you immediately. And it's going to kill you in this order. Airway. So we asked the patient, can she talk? And she's like, yeah, I can talk. That means there's nothing obstructing her airway. She can talk. Breathing, we take a listen to her lungs. She actually has decreased breath sounds on the right. So if you listen to her lungs and she takes a big deep breath, you can't really hear breath sounds on the right side. The left side sounds normal. Circulation, she's got palpable pulses in all of her extremities. There's no sign of any bleeding anywhere. And then disability is another word or term for a neurologic examination. She's confused, right? She's following commands. So we tell her to give us a thumbs up. She's able to do that. And she also opens her eyes spontaneously. So this is part of what we call the Glasgow Coma Scale. This is a really quick 3-point examination that's based out of 15. And we use this examination to let us know the likelihood of someone having a severe traumatic brain injury. Okay. And then E is for exposure, which means we remove the patient's clothes, we put warm blankets over her, and we do a thorough examination. So once again, in this order: airway, breathing, circulation, disability, exposure, ABCDE. Okay. ABCDE, in that order all the time. Never forget that. Okay. So if the patient has a little bit of some bleeding, or the patient, you can't get a pulse, it doesn't matter at that point if they can't get air through their airway. So that's why we do it in that order. You got to make sure that they can get air into their airway. There's nothing blocking it there. There's no teeth that are in there. There's no, the tongue is not back there. You want to make sure that's clear. Breathing, you want to make sure that they can have bilateral breath sounds. So you're going to see in the next slide that we're going to actually do something about the B section, which is the breathing section, and then circulation, disability, exposure, always in that order. So as we said, she's got decreased breath sounds on the right. Here are her vitals right here, right? Her heart rate is 102. Her blood pressure is 126/72, which is normal. And her oxygen saturation is 96% on RA, is short for room air. Okay. But we quickly get an x-ray because she's got decreased breath sounds. And as you can see on this x-ray on the right, that ain't right. That is not right at all.
That's too black.
Yes, that is all that black and gray is not good. That's air that's not in the lung. And actually the lung is everything that you can see. I don't know if you guys can see my mouse. The lung is everything here on the bottom corner right here. That's the lung. It is collapsed. This is also another terminology that we use is what's called the right pneumothorax. right? If you look on the left-hand side, you can see the lung is fully inflated. You can see markings of the lung that go all the way to the ribs and all the way around the shoulder blades and everything. That's normal. Okay, you can see the heart right here. That's normal. And if you look really hard, you can see the trachea right here. You guys see that trachea? And it splits into two if you look carefully, right? So she's got a collapsed lung on the right side, or something that we call a right pneumothorax. This is an emergency. We need to do something about this right now.
It's kind of amazing how we developed to have two separate cavities, one for each lung, left and right lung, so that we can live long enough for someone to fix us. Like,
that's right.
If the whole cavity was two lungs in one big cavity, like the whole lung would have collapsed and she would have died almost immediately.
It's crazy how evolution works, right? So we got to do something about this, people. All right. So this calls for something that's called a chest tube. Okay. So as you can see by this illustration right here, we have a gentleman who's looking right at us, right? And what we do is we numb up the skin in this second picture on the left, on the right-hand column. We're going to numb up the skin. Okay. And then what we're going to do is we're going to make an incision through the skin, and we're going to take some clamps, and we're going to go through the fat tissue. We're going to go through the muscle layer, and we're going to put a piece of plastic. And you can see this plastic that's right with this instrument. We're going to put it right underneath the lung, or right underneath the ribs, and right next to the lung. Okay. And in this last picture here, you can see what it looks like coming out of the skin, and we tape it in place. And this should allow the lung to re-expand. This is what we call a chest tube placement. Okay. We numb up the skin, make an incision. We put our clamps over the rib so that we don't hit the blood vessels that are running alongside the ribs. Right. And sometimes what will happen is when you go into here and you open up the muscle, you'll hear a big tss, and that's air that's just rushing out from this cavity that's trapped in here. You'll put your plastic tube in there, you secure it to the body, and voila, the lung re-expands, right? So as you can see, the lung comes right back up. The patient feels a lot better, right? This is what it looked like before. Your lung was all the way down here, and now it's fully almost up, okay? So we took care of B, and the rest of the primary survey is okay. So she's doing okay right now. So this chest tube is probably going to stay in for an additional probably 2 to 3 days. It depends on how sick she is. We ain't there yet. So just know that chest tube is there. So we get into the secondary survey. I'm not going to bore you guys with all the things that we do in a secondary survey, but basically we do a head to toe examination to make sure that we don't miss anything like lacerations or bruising or broken bones. So pertinent findings on this examination is on the head examination, the patient has bruising to the forehead and as well as the periorbital region. So around their eyes, the patient has some bruising. Okay. Now around the chest and the lungs, not only did they have, when you initially examined them, they had decreased right breath sounds, but now they also have some tenderness as well as some bruising to their right chest wall. And when you touch it, it hurts. They're like, "Yo, don't touch me there." So we're suspicious about some things that are going on in the right chest. And then the abdomen is firm. It's tender when I touch it at the left flank. And there's also some bruising at the left flank also. And then I don't know what happened to my extremity, but extremity is supposed to say that the patient has the right thigh looks weird. I'll just leave it to you like that. The right thigh looks weird. I don't know how that fell off. So, but you guys catch my
arrow.
joke.
It's probably it'll pop up when you click the button.
I don't know. Something happened. But anyway, this is what the abdomen looks like. This is the bruising that you see on the abdomen right here on this patient. Okay. Yeah. All right. That ain't good. We're worried about something. And she touches my hand when I try to say, "Hey, what's going on here?" That ain't a good sign. So that goes along with this firm, tender to palpation of the left flank and bruising at the left flank. Something is going on here. Okay. And then remember I told you the right thigh didn't look right. This is what the right thigh x-ray looks like. So she has a broken right thigh, right? So the technical term is right femur fracture. And there are multiple ways that you can have a femur fracture. There's fractures that kind of take a little bit of a diagonal direction. There's fractures where there's like multiple bones that are stuck in there. And then there's something that just goes right across like this. Okay. But ultimately, this bone is broke and it needs to be fixed. So Patient is stable. And we're going to go off to CT next. And the reason we're going to go to CT is the patient is stable. And there's certain things that I just can't see on x-ray. There's certain things that I can't see on ultrasound. So we're going to go to CT and kind of see what's going on. All right. So we go off to CT, right? This is what a CT scanner looks like. This is not our patient, but this is what a CT scanner looks like. And when we get a CT scan, she has a traumatic right subarachnoid hemorrhage. And you can see the arrow sign pointing to what you see as white, not the skull, right? The skull is this white hard thing that goes around, but these little white lines that appear to be on the brain. Okay. That's blood. That ain't supposed to be there. That's not good. If you look on the other side, it looks normal, right? You see normal brain tissue, but on the right side, you see these little areas of whiteness. That's called subarachnoid blood or hemorrhage. That's blood that's actually on top of the brain. That's abnormal. Now, we've went through the rest of the CT scans and we scanned the patient's chest, and you can see that this patient has fractures, right? You can see the circles which show where the bones aren't actually opposed to each other in the right direction. That's where the fractures are, okay? And if you see this little white line or this little gray line here, that's probably a collection of blood there also, something that we will call a hemothorax, heme for blood. Okay. And thorax for chest. So there's blood in the chest. So she's got rib fractures that you can see here. She's got a subarachnoid. And then we go down further in the abdomen and you see this bad boy right here. That's the spleen that's on the left side of the belly. And not only is the spleen cracked, right? The actual term is a grade 3 spleen laceration. But as you can see, this white line here, that's actually, when you get a CT scan, they actually put contrast in your bloodstream, and then your body picks up that contrast and it goes through different parts of your body. Well, if you have an actual cut in one of your solid organs, your spleen or your liver, you'll actually see some of that contrast leave the organ. And you can see that contrast just freely floating in the abdomen. That's what you see here. So we call this a grade 3 spleen laceration with active extravasation. There's a problem. This patient more than likely needs surgery. This is the reason why the patient has that bruising on her belly. All right.
So, Nii, a question that a lot of students are talking about in the comments is, how does this person, at least at the time of presentation, have a normal blood pressure with all of this bleeding?
Sure. So it's very possible that the patient can come with this amount of bleeding. The patient can come to the CT or come to the ER with low blood pressure. So blood pressure less than 100, and also heart rate that's really fast, someone that's tachycardic. It's very possible, but it's also possible that this patient can show up like this. And the reason why I presented the patient like this is most of the time people will be like, oh, this is not that big of a deal. But then when you take them to the CT scan, you're like, oh, snap. This patient actually has some real trauma. So yes, I would say the majority of patients will show up. Heart rate is fast. Blood pressure is low, but you never know, right? So as a matter of fact, this patient's blood pressure is fine enough for us to go to the CT scan, and this is what you see, right? So we're going to take the patient off, and there's two options we can go with this, right? We have new technology called interventional radiology, and then we have old technology, which is my knife, okay? So interventional radiology is where a radiologist can actually go into the groin, find one of the major arteries, which is the femoral artery, can snake a catheter up through the aorta and get into the splenic artery and actually possibly stop this bleeding without me having to operate on this patient. Super dope. We call that interventional radiology, or angiography and embolization. Is really, really cool, right? But if the patient's blood pressure drops, we ain't got time for that, because it oftentimes takes about 45 minutes to an hour for an interventional radiologist to come in with their team, his or her team, and actually do this procedure. And as a matter of fact,
they're sitting at home chilling, watching movies.
They're eating Doritos. And they're like, wait, what? Yo, I need an hour. I need an hour before I get in. So, we're thinking this is what this patient needs. So we're getting out the CT scan. We're getting ready to call the O or call the IR and tell the radiologist, yo, I need you to come in. But then the nurse says, yo, doc, we got a problem. And I'm like, what? What's the problem?
Uh-oh.
And they say blood pressure down to the 80s. And I'm like, oh, snap. This is the blood pressure right here, 81/55. Patient is tachycardic. Everything that you guys were asking about. See, y'all asked too many questions. Just let me go over my story, students. All right, let me go over my story. So the patient is hypotensive and the patient is tachycardic. The patient is in grade 4 shock. We have multiple grades to tell if the level of shock that someone's in. It goes from grade 1 all the way to grade 4. Grade 4, the body is telling you, if you do not get blood in me right now, I'm going to die. This patient needs to go to the operating room. And as a matter of fact, that's what we're about to do. So we tell IR we don't need them anymore. We tell the operating room, look, open up everything. We are coming. And usually when a trauma comes through, the operating room has multiple operating rooms. All the other surgeons are doing their elective cases, but most trauma centers have to keep a room open for a trauma like this that has to come emergently. And especially when the trauma gets called, they have to actually stop some operations, or excuse me, they can't allow any new operations to begin until they hear from me that the patient is stable. So now that I said that this patient is unstable, I need to go upstairs right now. They just already have a room that's waiting for me. And then as I say I'm coming up, they're actually opening up all of the instruments and everything and ready to go. So we're running. So we're going to the OR, right? We're getting ready. We're ready to do this. So they got everything ready for me, got the lights, got my gown on. We're getting the patient prepped and ready to go. And it's time to OR. It's time to operate on this patient. It's time for a knife. Okay. And this is what she needs. So we're going to do what's called an exploratory laparotomy. Okay. This is a really simplified version of it. Basically,
go back to that picture. Is that you there?
No, that's not me.
Is that you? Okay. I love that picture for one reason, right? The representation in that picture with both the surgeon and probably the surgery tech there. That's awesome. That's a great picture. Good job.
Thank you. Thank you very much.
I didn't think that was you. That man's much handsomer.
Damn, even through the mask, huh? Listen, in the world, we're going to have a major problem because there's a lot of people that people think look good through the mask. And when we start taking our mask off, there's going to be a lot of people who are like, damn, bro, you ain't that pretty, right? But anyway, so this is what an exploratory laparotomy looks like. This is a simplification of it. This is what a midline incision looks like. All right. And actually, to be honest with you, this is a small incision. For a trauma case, we're going to make it really big, actually. But this is something that you can kind of put in your mind as to what we're going to be doing. So we're going to be cutting through skin. I'm going to be cutting through subcutaneous tissue or fatty tissue. And I'm going to be cutting all the way down to the really strong tissue that holds the abdomen open or closed. I'm going to cut through that and get into the belly. Okay. And this is kind of what it looks like in another, cartoon representation. And I get in there and I take a look at that spleen and boom, there you go. That's what you see in what you call a ruptured spleen. Okay. So I removed the spleen from the patient's abdomen and you can see that cut right there. That's where blood was emanating out and contrast was emanating out.
Wow.
On this CT scan right here. Okay. So that's what you see right here. So that's what a spleen looks like on an operating room table or on the surgical tech's desk. That's the safest place for that spleen to be, not in the patient. All right, guys. So we finished the rest of the operation. She doesn't have any other injuries in the abdomen. We go ahead and we close her abdomen. Okay. But don't forget, she still has this. She still has this fracture here. What are we going to do about it? So in the operating room, we call the orthopedic surgeons. They come in and look, the patient is really sick. She has a brain injury. She just had her spleen taken out. Actually, we don't have time to do a definitive surgery on her femur fracture. So when we call orthopedic surgery in, they come in and they literally do the quickest thing they can do until the patient stabilizes. In this case, literally what you see at Home Depot, the drill at Home Depot, right?
That's a Black & Decker drill.
This is a Black & Decker drill. That's obviously a medical version, which means you can charge like $2,000 for it, right? But this is obviously a sterile procedure, but they're going to drill a sterile pin through this patient's right below the knee. And they're going to put this leg in traction. And what this is going to do is it's going to put the leg in traction. It's going to get the bone, the fracture, in proper alignment, which is going to reduce the swelling, reduce the pain, and also reduce the bleeding. Okay. So here's another picture of it. And you can see the actual pin go right through the tibia. Okay. So that's done. And then this is what it looks like on an x-ray. Okay. And then they're going to put some weight on it. Okay. At the end of the bed. And then we hope that it looks like this. So you can see it's opposed. Now, obviously, she had a fracture on her right-hand side, but work with me, everyone, right? You guys get the point, all right? So this is the best picture I could find. So this is it opposed or properly opposed. And hopefully the amount of swelling, the amount of bleeding has reduced. And what we're going to do is we're going to leave it like this for a couple of days until it is more stable for her to go to the operating room. Because really with a brain injury and what she just had in her abdomen, she really should not be in the operating room getting her leg fixed at this moment. Okay. So really it's abdomen and brain. That's the most important thing for this patient, not her leg. Life over limb. Just remember that. All right. So we get a consultation from neurosurgery. They don't even come into the CT scanner. They don't even look in the operating room. They just look at the CT scan and they say, look, ain't nothing to do right now. Everything's fine. Just give the patient anti-seizure medication for 7 days. The reason we do that is blood on the brain is actually an irritant and it can cause you to have seizures. So we give special medications that stop the body from getting a seizure or the brain from having a seizure. And we do it for 7 days. Okay. We use a medication maybe called Dilantin. Sometimes we use a medication called Keppra, but only for 7 days. And that's it. And then in 24 hours, we get another CT scan to make sure that the bleeding hasn't gotten worse. And other things that we do during these 24 hours before we get a second CT scan is we do a whole bunch of neurologic examinations. Hey, what day is it? Where are you? Give me a thumbs up, wiggle your toes, right? These are the things that we're constantly asking the patient on an hourly basis. And if the examination is good, then that's good. We get a CT scan in 24 hours. But let's say, for example, the patient is like, hey, what year is it? Blah, 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 blah. Give me a thumbs up and the patient can't do it, then we would not wait for 24 hours. We would get a CT scan immediately because sometimes bleeding can get worse. Okay. But in this case, everything is fine. Anti-seizure medication for 7 days, head CT in 24 hours. And now we're in the ICU. Right. So after the operating room, patient goes to the ICU and recovers. Okay. This is the best place for her next. The best part about being a trauma surgeon is I get to take care of her directly in the ICU. That's why I love it. Okay. So I'm still taking care of her up here. So post-op day 1, she wakes up the next morning. Patient is doing well. She gets her repeat head CT. Actually, the repeat head CT is stable. Looks fine. The bleeding the blood is not gone, but it hasn't gotten worse. So that's why we say it's stable. And as a matter of fact, neurosurgery says, you know what? She's doing so well that if she needs to go to the operating room, she can go to the operating room with orthopedic surgery. Blood pressure is within normal limits. She's doing okay. We say, let's hold off another day. Let's wait till the next day. So post-op day number 2, she goes to the OR with orthopedic surgery. They do their thing. They bring in more tools, all their fancy tools. They do their thing. And they put in what's called an intramedullary nail. And this is what it looks like. Okay. Basically, they put a nail that goes through the knee joint and kind of goes all the way up into the top of the femur or top of the bone right here where you see my cursor and that's it. Neurosurgery looks at the patient before they go to the operating room and they say, she's good. We're signing off. Patient can come back and see us in clinic. Right. But this is what post-operatively the patient looks like with orthopedic surgery. Patient is doing good though. So let's fast forward all the way to post-op day 7. The patient is eating now. The patient has pooped. The patient has been able to get up and work with PT. And they say, you know what? You're not ready to go home yet, but you can go to, I think you should go to rehab. So you're not ready to go home, but you're not ready to, you're too good to stay in the hospital. So patient is going to go to a rehab facility and work with this woman right here and just get exercise and get going. But before she leaves the hospital, she gets spleen vaccinations, right? So every patient that we see from a traumatic standpoint who gets traumatically injured and has to have their spleen taken out emergently, before they leave the hospital, we give them spleen vaccinations to protect them against certain encapsulated organisms. Okay. So she got her spleen vaccinations. She did well with PT and she's going to follow up with us in about 2 weeks. And that's it, guys. So she did well. I just want to say thank you, guys. And that's me right there. So
that's awesome.
I'm going to stop sharing.
That's awesome. All right. If you want to come on and ask some questions with Dr. Darko, raise your hand. We'll get you on. I'm going to remove these. I don't know if they want to be there. Some people are asking, maybe not the best question for you, but there was obviously a little bit of that bone fracture still floating there. They want to know what's going on there.
Leave it alone.
Leave it alone. Resorbs and fixes itself.
It's almost as if you had a bullet there. Imagine if it was a bullet there. We'd leave it alone. We don't touch it because it actually causes more damage to go after that fragment of bone or that fragment of bullet. Like you can injure nerves, you can injure vessels, as long as it's not like in a vessel or, it's not eroding into a vessel or there's no signs of infection. We just leave it alone. Yeah.
Awesome. All right. I just accepted 4 people to come on. Give them a second to stay there. Gian asks about how long do patients stay in the ICU on average? Do you have that kind of number?
So it depends on how injured they are. So a patient like her, realistically, she'd probably stay in the hospital or stay in the ICU. I'd say 3 to 4 days. Yeah. So she probably stayed in the hospital in the ICU 3 to 4 days. And then from there, we transferred her to what we call a step down, which is, it's not the ICU. It's not the ICU. It's not the floor. It's kind of in between. And then from there, she goes to the regular floor, and then she goes to rehab afterwards.
Nice. How nice is it potentially to not have to deal with insurance companies, because it's trauma. It's not like you need a prior authorization. Like, this patient's dying. Are we allowed to take her in for surgery? You just do your thing.
So yes. Okay. I think from an initial standpoint, yeah, there's a lot of things in trauma that are amazing. Like, you don't have to worry about labs. You don't have to worry about insurance. You don't have to worry about really anything. You just need to take care and make sure that this patient lives, right? The golden hour. But I'm not going to lie to you guys. Like, insurance does play a role afterwards, and it plays a role in ways that unfortunately is a problem sometimes. So, she just happened to have good insurance. She's 23. She's still under her her family's insurance. So she can go, her insurance will pay for an acute rehab facility. Nice. But depending on where you're at, if you're in indigent areas, like if you are in inner city areas where patients don't have insurance, or, they just don't have insurance, patients, it's expensive to go to rehab. And if they don't have insurance, unfortunately, they may not be able to go to rehab. So sometimes patients will either linger in the hospital, or they may have to just go home, and it just takes longer for them to recover. So insurance, unfortunately, rears its ugly head with us on the back end side. So we can't necessarily get around it, but it plays a bad role sometimes.
Yeah. All right, Adam, unmute yourself. Say hello. If you can. There you go.
Hey, you guys can hear me?
Yep.
Perfect. I just want to say, Dr. Darko, I'm a big fan. I heard you first on your episode with Dr. Karen Menteng for Solving Healthcare.
Oh, yeah.
So I'm really excited to get to hear you speak.
Yeah. Mm-hmm. Yep. And you got his name right, man. That's
yeah. I'm actually in Ottawa, so Canadian joining in here.
Yeah. It's my Ghanaian brother. Yeah.
Yeah. So I was actually just going to ask about that. So in that episode, you talked a lot about physician burnout. And as a trauma surgeon, I wanted to know, obviously, you've talked about you've had like an amazing work ethic. That's what got you through med school, going at 4 a.m., staying till 8 p.m. But how do you manage your long hours, and especially in trauma surgery, like really hard situations with patients? How do you manage that with your mental and physical health?
Good question. So, the trauma surgery has changed dramatically. It's not like ER medicine in terms of, obviously we're dealing with trauma patients all the time, but we've adopted the ER model of shift work with trauma. So that means that I work for like 12 hours and then I'm off for 12 hours. So technically I don't really have any patients. My group of trauma surgeons like own the patients. And why we do that is, when I'm off, and my patient and my partners take care of my patients as if it's their patient. right? And vice versa. When they're not on, I take care of their patient as if it's my patient. And that allows a huge mental relief where you can be like, you know what? I'm going to push it hard for 12 hours and then afterwards I'm out. Now, obviously, if I'm operating on this lady and it's 11:30, 11:45, almost 12 hours, I'm not going to be like, oh, that's it. I'm out. Peace. Oftentimes you're there, 14, 15, 16, 17 hours just to get the job done. And then, you're out. But your partners are making sure that nothing new comes in after that 12-hour span, but you're not going to leave your patient on the operating room table. But I think also, there is realistically, you have to be able to take time for yourself. You have to be able to realize that, you can't save the world. And there is a little bit of, I like to say a little barrier or a little bit of some space that you need to have with your patients, because I'm not going to lie, you can take things home with you, right? Like you're literally going from 0 to 60 on each patient. And sometimes that you can be driving home. And although you're not driving, 100 miles per hour, but you're still carrying that stress with you. It takes a while. It takes some time. But I've learned to be a lot more, mindful of these things. I did everything that I can for these patients. And then once my shift is over, that's it. It stays at the hospital. And when I'm with my family, when I'm with my wife, when I'm with my kids, when I'm podcasting, that's where I'm at, and that's been a game changer for me. It's not perfect. If someone tells you it's perfect, they're lying to you. But it's that's what we do, so good question.
Love it. Thanks, Adam. All right, Esther.
Sounds like you.
Hi. Can you hear me?
Yep.
Okay. So my question is, as a DO, have you ever faced any, I'm not sure if discrimination is the right word, but one of the setbacks that I've heard about as a DO is that, especially in other countries, they're not as accepted as MDs, and some countries treat them like they're not actually real doctors. So I was wondering if you ever faced anything like that, maybe outside of the country or in the country.
So I do medical humanitarian work with my wife in Ghana. That's where I'm from. And my wife also does medical humanitarian work in Haiti. She was actually just there. Not just there, but she was there for the earthquake. Haven't had any problems. Ghana recognized osteopathic physicians a while ago. So we haven't had any problems doing, medical humanitarian work there. I know several DOs who do work in Togo, work in all over the world. But there are also, you got to be cognizant that osteopathic medicine is taught a little bit differently in countries outside of the United States. So the countries that do teach osteopathic medicine, I can't remember, they do something that's called osteopathy. Right? Yeah. Not osteopathic medicine. So for them, osteopathy is more similar to kind of just all manual medicine. Right.
It's more similar to physical therapy.
Right. Right. It's very, they use manual medicine. That's the only thing you just have to be cognizant of and be able to justify, which is not hard.
Okay. Thank you so much. And I really appreciate that because I'm Nigerian. And I'm also, in the future planning to do something along the humanitarian side. So thank you.
Oh, you're welcome. Good question.
Nice. Thanks, Esther. Ravanya. Hello.
Hi, Ravanya. How are you?
Hello. Can you hear me?
Yeah, we can hear you.
All right. Well, thank you so much for your presentation. I'm actually a registered nurse, and I work in the ICU, and I'm also worked in the emergency room. So,
did I say it right? Did I represent right?
Yes.
I know you. He's checking everything.
It gets real dirty sometimes.
I don't know if I heard enough love for nurses while you were talking, but we'll talk about that later.
I'll tell you something right now. You can't. Everybody who's listening right now. The other thing about trauma, which is super dope, is this is a complete team effort. Mm-hmm. There is but obviously the trauma surgeon is running the service and making sure everything runs, but the trauma surgeon cannot do much without his nurses, or her nurses cannot do much without the radiology techs, without the phlebotomist. Like, this is a team effort that everybody has to be trained for. It is unlike anything else in medicine. I'm very serious. It is unlike anything else in medicine, and the type of training that they have to get, particularly trauma RNs and ICU RNs, is second to none. So we don't sleep on that. So it's a good point, Dr. Ryan, what you brought up.
Yeah. Watching trauma is very special as you go through this process.
Okay.
All right. Ravanya, you still there?
Yes. Can you hear me?
Yes.
Yep.
Okay. So I just wanted to ask a question. I know here in the past couple of years, there's been conversations that are kind of uncomfortable for people, but I definitely wanted to ask because it's something that I think about when I go into medical school and residency. Do you face, problems, or have you ran into problems where because you're a person of color and not being in the majority, do you face problems, or have you ever had problems, and how do you deal with that in the workplace?
So in residency, I went to a historically Black college and university medical program or residency program, Morehouse, which was the best training I've ever had. It's the best thing I've ever had for me. But the training that we had was at a facility called Grady Memorial Hospital. I don't know if you guys are familiar, but it's the largest trauma center in Atlanta for at least 100-mile radius. Grady Memorial Hospital is built like an H, right? It's built like an H. So it's a 1,000-bed hospital that's built like this. And then there's a line that goes right between it. And that's where people walk through and so forth.
Those
right?
were the hospitals I worked at.
So you know where I'm going with this.
Yes.
Right. So there's an A and B wing,
Mm-hmm.
and then there's also a C and D wing, right? And then not only that, now that you guys understand how that hospital works, we share the hospital with Emory University. Okay. So we compete with Emory University in a positive fashion. Because they're a larger program, they took care of 75% of the patients, and we took care of a quarter of the patients, right? So with that being said, the A and B wing used to be for white patients only. And then the C and D wing used to be for colored patients, right? That's the terminology that they use. Used to be for colored patients only. Obviously, as desegregation occurred with Medicare and so forth, they were forced to desegregate. Otherwise, they weren't going to get Medicare money. And things have changed from this, from the 40s and 50s, and then Medicare passed, and then onwards, right? So actually, the C and D wing doesn't even exist anymore. It's just all administrative buildings. But a lot of those remnants are there. Right. A lot of those things are in the back of your mind, like, whoa, I'm in a hospital that literally 40 years ago, like I probably would not have been able to either practice here, or if I was a patient, I wouldn't even be on the A and B wing. Right. That's something to be cognizant about. But also as a resident, there were times where, when we were on trauma call, we take all the trauma for the whole city of Atlanta during the time for that day and night. We would oftentimes, not often, but we would have patients who would come through, and you can't, when you're a trauma patient, you can't pick who your doctor is, because you're just like, look, man, I'm about to die. Do something. Right. So, like seriously, like it's the truth, right? Do something. So, when you're about to die, you don't have any choices. But there were times where we had patients where we had that same exact case presentation where they go to the ICU, they wake up the next day and they're like, doc, you guys are with which service? We're with Morehouse. Well, I thought this isn't Emory here. Can you transfer me to the Emory service? Right. And we're like, but we took your spleen out, we closed you up and all. They're like, no, I feel more comfortable. I was with the Emory service. All right. What are you going to do? Now there's so many different ways you can go around it. Right. And say, oh, well, they just want the higher, esteemed service and so forth. Who knows? Right. But we kind of know what's going on. So, I had that type of experience, but to be honest with you, once I left fellowship, I think I was really cognizant early on of what the effects of imposter syndrome and what the effects of, well, what does this person think about me could do to me for my mental health. So I just said, I'm tired of it. I don't want to deal with that. I'm trained. I got my board certifications in trauma and general surgery. I did everything that I needed to do. So I was just like, forget y'all. I don't care. I am really well trained. And there are places where as a surgeon where I would work in areas where I was like the only physician in a long period in a big area. And everybody there was sweet to me. So I thought, right? Everybody was sweet to me. I never had any problems. But to be honest with you, I never really put that in my mind. I just kind of just did the best work that I can do. And I think I realized maybe a couple years into it that I got to kind of let go of some of those things, because although it's there, if I internalize it, literally I'll be going home tachycardic and on, with high blood pressure. So I decided to release that, and whatever people think, I let them think it. But they should know that they're going to get the best care from me. And I represent Morehouse to the strongest, to the best. And I represent Kansas City University to the best. And I leave it at that.
Thank you so much.
You're welcome.
All right. I love that mentality, right? You can only control you. That's awesome. Alexander. Hello.
Hi, can you hear me?
Yeah.
Yeah.
Awesome. So my questions are, what kind of markers do you look for the brain trauma versus the spleen? And how do you monitor that? And then also, how would you treat a patient who came in with a more serious head trauma?
Sure. So the markers that we look for are during our during our primary examination, when we get to D, I don't know if you remember disability, that's our neurologic examination, right? That's a very quick neurologic examination that is made of 3 components: your eyes, the ability for you to phonate and say something, and the ability for you to follow commands. Those 3 examinations can let us know if you have a severe, mild, or moderate traumatic brain injury, right? And after that exam, then we do our head to toe examination, which includes looking at the pupils and some other things like checking their back to see if they have any spine fractures or within their neck or their back. So what I'm looking for is, is pupils, are they unequal? Are they confused? Are they saying something? Are they kind of like this, which portends a really bad brain injury? Or are they kind of like this, which also portends a really bad brain injury? Those type of patients will not have what you saw in the CT scan of their brain. They'll have a far worse injury. Now, someone who has a far worse injury, like what you would hear like a subdural hemorrhage, which is like a big collection of blood that's pushing on the brain, and those type of people come in like this or like that, those are the type of people that would probably, if I took them to the operating room, I would say, neurosurgery, you need to come in and take a look at the CT scan and meet me in the operating room, which has happened. They come into the operating room, and not only is the head shaved and they're operating on the brain, but I'm also operating at the same time at the belly, right? Because at the same time, both are equal. If the patient loses their blood pressure, then it doesn't matter what you do to the brain. They don't have enough blood pressure to get to their brain. And then the same thing, if I do this great surgery, but then they're brain dead, where we at? So oftentimes, we do things at the same time. It doesn't happen often, but it can occur. So those are the things that we look for. Post-operatively on a patient like this, the same thing. Give me a thumbs up. Tell me where you are. Things like that. We ask those type of questions. Those are what we're looking for. Now, in this type of patient, if afterwards she was just like, yeah, I don't know where I am, or, she starts talking like this, like it's looking like she's having a stroke, we would send her quickly to CT and get a repeat CT scan to see if her scan got worse. And then obviously neurosurgery would be there, and they may have to operate and do something else.
All right. Thank you. Thank you for your presentation. It was awesome.
Oh, thank you. Glad you enjoyed it.
Last but not least, fan favorite Shane.
What up, Shane? How you doing?
I'm doing pretty good. How about you?
Good.
So you kind of hinted this actually in the previous question. You mentioned earlier that with the spleen, you had 2 options: either ask the IR doc to come in or do it yourself. If the situation is an emergency, but you can't do it yourself, what happens? And someone's, 45 minutes away, half hour away. Is there anything you can do to start the process or anything or does you just have to let it all happen?
So if IR can't, so the fail safe for anything is me. So if it doesn't work, I got to be able to cut it out. That's it. There's no other choice. But if the patient is stable, so we put the patient in 2 tiers: stable versus unstable. If the patient is stable, then I have options. The options are to have an interventional radiologist come in and see if they can stop the bleeding. During that time, I can give the patient blood, right? I can give the patient blood to kind of keep their blood pressure stable in anticipation of blood loss. I can do that, right? And we hope that that's the case. If they get up and they start working with physical therapy and they maybe bend over the wrong way and then they feel a pop, and then all of a sudden they're like, "Doc, I don't feel too good." Their blood pressure is low, and then you get a CT scan and their belly is full of blood. And what happened is the coils that they used to stop the bleeding popped, and they need to go to the operating room immediately. So the ultimate fail safe is me as a trauma surgeon.
And would you say that applies even for neurosurgery or any orthopedic injuries or anything like that?
Yeah. So surgery is always the fail safe for everything, and it's not a cocky thing, but it's always the most conservative thing you can do. So in this patient who has a spleen injury, actually it's not conservative to not operate on this patient. The safest thing you can do on this patient is to take her to the operating room and remove her spleen. Wow. So to to take her to IR, you have to have a heightened sense of, okay, what we're doing could fail, right? And if it fails, I need to be ready to take him to the operating room. But if I decide to be like, I don't want to deal with this, I'm just going to take the patient to the operating room. We can't play no games. Mm-hmm. That's the safest thing. That's what's called conservative treatment, actually, in this situation.
Gotcha. Okay. Thank you.
Do you ever look at the call list and be like, Dr. Smith's on for IR. I don't want to deal with her. I'm going to the OR.
So,
you don't have to answer
no, we can't. From a legal standpoint, no. Medical reason, no. But we'll leave it to you like this. If the patient can, an operation is a very traumatic thing for a patient, right? So back in the 70s or in the 50s and the 60s and the 70s, before CT scans were prominent, right? Later on, or maybe they developed scar tissue, right? Adhesions afterwards. So it's not a benign process. So CT scans have really revolutionized the way in which we take care of people. But ultimately, it's always a surgeon's preference to do the safest thing. So if we can do something where we don't have to cut the patient and they're stable, we'll send them to IR.
Nice.
Gotcha. Thank you so much.
Dr. Nii Carko, if students for some reason want more of you,
why would they want that, right?
Docs Outside the Box is your own podcast where you're crushing it. Is that still active? I haven't checked in lately.
Absolutely. Still active. Still doing it. We're almost 250 episodes. Actually, we're over 250 episodes. So Phenomenal. We're expanding to YouTube. We're expanding. So we're super excited. Super excited.
YouTube,
keep going.
I don't know about you, but YouTube, not getting into YouTube sooner is my biggest regret, doing this whole media thing. But we're on YouTube now. So Docs Outside the Box, podcast, YouTube, anywhere. Talk about your wife. What's your wife up to? And where can people find out more about your wife? Because she's out helping a ton of pre-meds as well.
Yeah. So my wife is look, my wife is my Michelle Obama, yo. Like, seriously, like, she is smarter than me. She's doing way more doper things than me. But my wife is Dr. Renee Volney Darko. You can find her on social media as Dr. Renee Darko. But she is working with underrepresented minorities who are trying to become medical students. So underrepresented minority pre-meds. Okay. So make sure you go and follow her on at Dr. Renee Darko. She has an app that she's working on. Just follow her and you can follow her there. But she's doing amazing work within that realm. And, she's just, like I said, she's amazing. She's doing better things than I'm doing. She's making me jealous.
Stop it. You're making me look bad. I gotta talk about my wife that way. I appreciate you. I appreciate your time. You're awesome. We need to connect offline and see what you're up to and what I can do for you.
Absolutely. I know you're a busy man.